Well, good morning. Thank you for joining the Surgical Collaborative of Wisconsin Pediatric Initiative presentation. We're going to be talking about umbilical hernia repair in kids. We'll get started here in just a second, but just by way of introduction, I'm Jonathan Kohler. I'm a pediatric surgeon here at UW-Madison, and I put this program together with some pediatric surgeon colleagues at Medical College of Wisconsin as well. It's a project that's sort of been near and dear to my heart for several years now, and I'm excited to be able to share it with you today. As you'll hear, this is one resource that we're making available around pediatric umbilical hernias, and I'll be talking a little bit about the data behind sort of what's driving us to be interested in this, and some of the other resources that we have available to both for surgeons and for primary care docs and for parents. Just assume everyone at this stage in the pandemic is very familiar with Zoom, but feel free to use the chat function if you've got questions as we're going along. And then my goal is to talk for a bit, but then be sure that there's plenty of time left for questions at the end. Also, if you wouldn't mind, if you could just put your name and affiliation in the chat box, just so we have some sense of who's joining us, that would be awesome. Any questions before we get started? All right. So, like I talked about before, we're going to be talking about pediatric surgical care and specifically umbilical hernias today. And this is a project that originated with me, and then I was working with Marge Arca at the Medical College of Wisconsin until she moved to the University of Rochester, and then John Densmore has been our partner there since then. This session is approved for an hour of CME credit. The way to do that is to text that code ZUGKAD to that number 608-260-7097. And I can put that in the chat box too later, but that's the number to text, or the code to text to that number, and then that'll lead you to our accreditation website, which is not the most easy thing in the world to navigate, but it's not that bad. And at the end of it, you will have an hour of free CME. No disclosures. We used rights-free images and permission from patients. We are recording the session, and it may be used for eventual rebroadcast. And so if we're talking, just be sure to not include any PHI. All right, so like we discussed, we're going to be talking about this project that we've developed through the Surgical Collaborative of Wisconsin. We're going to talk a little bit about sort of the broader scope of pediatric surgery in Wisconsin and across the country, mainly just to make the point that general surgeons still operate on children a lot. And so there's a lot to do to sort of stay up to date with the best practices for that. And part of our goal at the Surgical Collaborative of Wisconsin is to be a central resource for those sort of best practices that can help people who have a lot to keep track of and up to date with in their own practices and their communities. So we'll talk specifically about umbilical hernia repairs. We're going to talk about some of the new guidelines out around that, some tips and tricks from a technical standpoint, and then just review some of the data about what current state is in the repair of umbilical hernias. And then I'm going to talk a little bit about some more resources that are available if you're interested in learning more or pointing colleagues in that direction. And then I would love to have a conversation with you guys about what is important to you, what's interesting to you, what about this makes sense, what doesn't, what we could do to provide more value added to your pediatric surgical practices. All right, so let's talk about children and the specifics of children care, or pediatric care. So about 60% of pediatric inpatient operations are performed in children's hospitals, and the other 40% are performed in adult hospitals by non-pediatric specialists. it's certainly will come as no news to anybody who's spent any time in Wisconsin, but we have lots of small communities without large children's hospitals. In fact, only really 2 communities with them, and Marshfield and La Crosse that have some pediatric surgical coverage. So many children live relatively close to an adult hospital and quite far away from a pediatric surgical care. And many of the operations, if 40% of pediatric inpatient operations are performed in adult centers by adult surgeons, then many more than that are performed in the outpatient setting. So we think that this area of outpatient procedures, is an area where children are getting operations in their communities very appropriately, and we just need to be cognizant on our part as pediatric surgeons about our role, not just in sort of vacuuming up complex pediatric surgical care, but in helping these kids stay in their communities, because no one wants to drive 5 hours for their umbilical hernia repair. This is all part and parcel with something called the American College of Surgeons Children's Surgical Verification Program. It's been around for a few years, and much like the trauma center designation, children's hospitals or hospitals in general can be certified as level 1, 2, and 3 centers for children's surgical care. Level 1s are sort of like the big quaternary children's hospitals, and level 3s are sort of more smaller places where people are not pediatric specialists but have sort of demonstrated some programmatic interest in developing pediatric surgical care. One of the things that level 1 centers do, much like the trauma centers reach out to the community to help them do better trauma care locally, part of being a upper level children's surgical center is creating cooperative relationships with other hospitals and trying to create good pathways for kids to get good care in their communities, and then also have an established pathway for transfer to larger children's centers. So this is in part of keeping with that mission, and also very much keeping with the mission of the Surgical Collaborative of Wisconsin, the goal of which is to create a community of surgeons around the state who are committed to taking good care of patients and measuring their outcomes and developing resources that help everybody be better. So let's talk specifically about umbilical hernias. It will come as no surprise to anyone who's practiced surgery for any length of time that they're among the most common procedures performed, often in adults as well, but among the most common operations performed in children by a big margin, sort of tied for first with inguinal hernias and appendectomies. They're often performed in communities. And what got me interested in studying this is that there really seems to be quite a lot of variation in care. Despite the fact this is a common condition with a pretty standardized operative approach, there just seems to be a lot of variation between communities and between states in when and how we manage them. So I started studying that, and that got me interested in kind of what the best practice is and what the best practice should be. So when we first wrote this talk, this guideline didn't exist, but in November of last year, the Choosing Wisely campaign, which is run by the American Board of Internal Medicine Foundation, but which partners with all sorts of professional groups, and in this case, in combination with the American Academy of Pediatrics section on surgery, came up with this guideline for how we should manage umbilical hernias. And basically, you can read the whole thing, but it says that we should avoid referring most children with umbilical hernias to a pediatric surgeon until 4 or 5 years old. The basis for that being that the risk of incarceration is very, very low. It's kind of statistically modeled and is probably around 1 in 10,000. And the chance of closing is very, very high, probably in the neighborhood of like 90% by 4 years. Related to this, the AP also came out on the same day with another recommendation, which is to reduce postoperative opioid requirements in pediatric patients by administering acetaminophen and nonsteroidal anti-inflammatory medicines in the perioperative period. And as I'll talk about the intersection of opioids and umbilical hernias is quite interesting. So for a surgical audience, this is probably the least necessary slide in the whole presentation, but as you know, an umbilical hernia is the fascial defect in the umbilical wall, not the overlying skin, but the actual hole in the fascia. It's present in about 20% of newborns, about 90% closed by age 5. And what predicts closure is really not known. There's been, I mean, I remember in my training, it was said, you know, oh, if it's like 2 finger breadths, or if you can, if it's proboscoid, so if there's sort of an elephant trunk of skin, it's less likely to close on its own. It turns out if you go back and look at the existing literature, which we did, there's really no good data to suggest kind of how to predict which hernias will close and which will not. I mean, they're recorded as closing spontaneously out to age 14. Enormous ones have been demonstrated to close. Small ones have been demonstrated not to close. It's really all over the place. Part of this is just the fact that like the belly button is hiding in plain sight. It's a pretty understudied area. And so the data is not great at baseline, but we're pretty confident that the size of the hernia and, you know, how big it looks on the skin, though obviously that's the thing that's the most interesting and alarming to parents, is probably not the underlying problem or predictive of whether it's going to close, right? So it's the fascial defect, not the skin, that you need to be thoughtful about in terms of closing. And I've seen patients come in with this sort of proboscoid umbilical hernia, and then you actually feel for a defect and there isn't one, it's closed, and that's just residual skin that over time will flatten out. So before we get into some of the epidemiologic data, I thought it'd be interesting and important just to talk technically about how we do this operation. And there's some sort of key points that I think are important that differentiate pediatric umbilical hernia repair from adult umbilical hernia repair. The biggest one being that the children will continue to grow, and so you try to avoid putting things in that will not. For that reason, we use absorbable suture. These kids are going to their fascia is going to heal in the time it takes absorbable suture to absorb, and if it hasn't healed by the time, you know, a vicryl or a PDS has absorbed, then probably it would never have done so. Definitely don't use mesh. It will not grow and can cause a lot of problems as the body tries to expand around an incorporated mesh. This happens, you know, if, at least according to coding data, you know, about every year, about 10 kids get mesh repairs with umbilical hernias, like little kids. Their kids' fascia is basically like rubber. You can close enormous defects primarily under minimal tension. Always important to resect that sac back to healthy fascia, and I've got a little video of that. And some people talk about doing really complex umbilicoplasties. There's all sorts of pediatric plastic surgery textbooks that describe elaborate shapes that you can kind of cut the skin into and then close it down. It doesn't seem as though any of that has really been borne out in the literature in terms of providing long-term benefits. I just tack a lot of redundant skin down to the fascia to just make it a little bit more flat in the immediate post-op period. And then over a year, you should see remodeling where things kind of flatten out. There's always a lot of question, I think, from people who don't do it all the time about local anesthetic in these kids. Conveniently, the way that they have designed, either by accident or on purpose, the dosing of Marcaine, if you use 1/4% Marcaine, it's just 1 ml per kilo. And if conversely, if you use 0.5%, it's 0.5 ml. So 2 fairly easy dosages to remember. Obviously, you want to check with your anesthesiologists, make sure they weren't giving lidocaine when they did the endotracheal tube, or if you're doing combined procedures, you got to be sure that someone else didn't also put in some local, but the dosing's pretty straightforward. And then we only use Tylenol and ibuprofen and cold or hot packs, depending on what the kid prefers after surgery. So we send these kids home with no opioids. So a couple different approaches surgically. This is sort of the classic infraumbilical smile incision. This is a kid that I did. This isn't actually my typical incision, but this is a kid who had a previous umbilical hernia repair that had recurred. So we use that old incision, and that's just that infraumbilical incision. One thing that's pretty cool actually is if you make just like a stab incision right underneath the belly button and put a hemostat in there and spread it, you will get this incision exactly, kind of following lines of tension. So you don't even have to make that whole incision. You can just make a little stab and then spread it open to get that. I actually use a transumbilical approach. That's our standard approach here just for getting into the abdomen for every laparoscopic case. So it's just something that we're familiar with. So we go straight vertical through the belly button, like right through the middle, and then you can find the native umbilical defect if you're trying to put in a port, and just go straight in there. But if you're just doing an umbilical hernia repair, you skip that step, and you just open up basically into the sac and then dissect around the sac. So got a little video, kind of just get down to that fascia. Getting down flat to the fascia, coming around the hernia sac there. Oops, sorry. When you're done, you're left with a fascial defect that should be a hole. It's usually about 1 centimeter, but obviously can range wildly. That's back, a nice rim back to healthy fascia, and then you just close it up. And then, there's a million ways to close fascia. I don't think there's any particular right way to do this. I'll often do like 2 figure-of-8 vicryls. Some of my partners will run a PDS. Some will do interrupted vicryls. And we've not identified any like variation in outcome based on that. I think it's just however you're comfortable in fascia close. And then in the skin, for us, we use interrupted 5/0 fast gut sutures. And it's quick and easy, but obviously a monocroral subcuticular or anything you like would be fine. If you're going kind of through the belly button, it can be challenging to do a subcuticular. So I think that's an advantage if you're going through the belly button, just to use that like interrupted stitch. It just goes right through the skin, and tell the kid he's going to have a few little hairs in his belly button. They fall out after about 5 days. Tegaderm and 2x2 for dressing, and you're off to the races. So I think, you know, the technical aspects of repairing a pediatric umbilical hernia are pretty straightforward, but the decision-making around it, it turns out to be pretty complicated. And we've done a bunch of work trying to understand that. And the reason why we've done that work is because when I moved to Wisconsin 5 years ago, it became clear that we were, as a state, repairing umbilical hernias pretty early. And actually, one of the first cases I had as an attending was an 8-week-old who was transferred to us after an elective umbilical hernia repair who developed a necrotizing soft tissue infection of the abdominal wall. And I thought, is this like unusual, or is this just something that's standard practice in the state? So we actually looked at the data, and there's not great outpatient data around ambulatory surgery in children. So unlike inpatient surgery where there are sort of comprehensive data sets, you're sort of left looking state by state, and then you're reliant on states that, you know, reliably report all of the operations performed in children across all of the different places where children can have surgery. Long story short, there's not that many places that you can compare to one another, but Florida and New York have very comparable data sets to Wisconsin, which actually has probably the best data set for state ambulatory surgery of any state in the country. And so this is just plotting out age of hernia repair, and then the y-axis is the rate of operations per 1,000 children. So sort of adjusting for the fact that Florida and New York are significantly larger. And you can see that we just are really different here. The typical umbilical hernia repair here, you know, about 50% are repaired before age 4. And about 30% are repaired at or before age 2. And why does that matter? I mean, well, one, we do know that these umbilical hernias will close on their own frequently by the time a kid is 4. And so if you're repairing umbilical hernias routinely at the age of 2, there's a good chance that some of those would go on to close by themselves. And some people say, like, you know, it's just an umbilical hernia. Like, what's the big deal? You know, it's important to keep people comfortable and make your referring doctors happy and make sure that parents aren't upset. But the reality is that it's more expensive, and it leads to longer length of stay. So we've looked at, this is national data looking at payments around the age of repair, and these are single procedure elective umbilical hernias performed as outpatients, and they are demonstrably more expensive when you do them younger. And the complications are significantly higher. So chance of coming back, of being admitted, is significantly higher, and the chance of coming back within 30 days to an emergency department is significantly higher in these populations, particularly the young kids. And then opioids are prescribed for these children. They're prescribed a lot. If we sort of look at national samples and looked at regional breakdowns, you know, down in the South, it's like 50%, maybe 30% in the Northeast, and everyone else is a little bit in between. And it's across all ages, a little bit, yes, less in the really young kids, but, you know, by the time you're 2 or 3 year olds, they're getting, at least 42% of them are getting opioids in a national sample. And they're not just getting like a dose or two. You know, about half get sort of the classic 1 to 3 day duration dose, but kids are getting 4 to 10 days of opioid prescriptions, some cases 10 days or more. And about 6% of those patients are getting a second prescription of opioids. So the sort of 6% rule that you often see in opioid dependence seems to hold for pediatrics. Whether it's like the kids actually needing them or them getting diverted is a little bit less clear, but 6% of these kids are getting redosed with opioids after their umbilical hernia surgery. And then what are they getting? So kind of varies. Hydrocodone, so Vicodin is pretty popular. Percocet is pretty popular. Straight up oxycodone, less so. Tramadol, not used very much. But this is important. Codeine, so this is Tylenol and codeine, so Tylenol 3, is prescribed to about a quarter of these patients, regardless of age. And that's important because there's actually a black box contraindication to prescribing codeine and tramadol, but tramadol is rare, but black box warning around prescribing codeine to any child under 12 who's having surgery. So these are kids who are being put at pretty significant risk of codeine-related complications, mostly hypermetabolism causing respiratory depression. You know, again, for an operation they might not need, and for an operation that in many cases, you know, just needs Tylenol and ibuprofen. In Wisconsin specifically, we're at about 50% for opioid prescribing. And we do a pretty good job of minimizing codeine prescriptions here. So it's about 4%. So to address the opioid question, we actually have a whole separate set of tools. We have a website called saferopioids.com. And on that website, we actually have a little 3-minute video about codeine and tramadol. You can take it for credit. You have to just answer some questions, or you can just watch it. It's about 3 minutes long, about the importance of not prescribing codeine and tramadol to young children. There's also a bunch of other resources on the Safer Opioids website around opioid prescribing for children and opioid prescribing in general. And you can get opioid CME by watching those sessions. And you can find them all online. They're geared towards many different specialties and procedures. Most recently, we've done a bunch of work trying to understand kind of just the social reasons why umbilical hernias are being repaired in children, and when the decision to repair them is made, and who's making that decision, in a series of qualitative interviews of surgeons, primary care providers, and parents. And that's all being written up for publication right now. But what I can tell you, kind of broad strokes, is that unsurprisingly, umbilical hernias concern parents. They want their children to be, you know, fit some vision of what a perfect child looks like, and that does not include a big proboscis coming off the belly button. They are, you know, they take their kids to primary care physicians. Primary care physicians often are not certain about what to do with umbilical hernias. They sort of don't feel as though they're up to date on what the current guidelines and best practices are. And they often want a surgeon to weigh in on whether there needs to be an operation. And then they also want a surgeon to sometimes just help parents of young kids feel more reassured about waiting. But when we talk to surgeons, the sort of frequent answer that we would get is that when primary care docs send a patient to them, like they feel there's an expectation that they do an operation, and that operation, that refusing to do an operation could potentially hurt your referral base, could sort of impact your relationship with these primary care docs. And that, parents, by the time they arrive at a surgeon, are expecting surgery. And so talking parents out of an operation kind of feels odd to them, or as though something that they're not really empowered to do. So we've tried to address all of those issues in a series of 3 short videos. These are like 3 to 4 minute videos. We've got one for parents, one for PCPs, and one for surgeons. And they're going to be available on the Surgical Collaborative of Wisconsin website very soon. They were going to be up today, but we're having a YouTube issue. So if not later today, then certainly very soon, all 3 of these will be up there. The surgeons is a sort of shorter version of this talk. For PCPs, we talk a lot about self-efficacy and sort of understanding what the guidelines are and feeling comfortable telling kids and parents that it's okay to wait. And then also the importance of, if you're sending a patient to a parent, sending a parent to a surgeon, to talk about reassurance and telling them that they don't need to have an operation, that it's really important to obviously make that clear to the surgeon before the parent arrives. And then for parents, it's a lot of just anxiolysis, trying to reassure them that these hernias are not dangerous, that they often close on their own, that they often don't require surgery. All right, and with that, I will close the presentation, but I would be very happy to take questions or comments. And thank you for putting in your affiliations there. I'm going to also, feel free to use the chat box if you've got questions, or ask them on your own. Don't feel.
Hi, this is Mike Schmidt from Wausau.
Hey, Mike.
Just had questions about making the incision through the umbilicus. Have you seen any infection problems? That sometimes gives me a little bit of pause going through a deep umbilicus, but if there's one that's protruding, I suppose it's maybe less of a risk.
Yeah, I mean, it's like hanging out in the air for an umbilical hernia, but yeah, it was not something that I had ever done before I started here. And the first few times I did it, I was like, this seems strange. Like I'd always, you always go around the belly button. Like the idea of going through it was a little bit scary. I will still do like an infra-umbilical on like a really deep belly button. If you're doing a lap chole on a 150 kilo patient and like you can't even see the bottom, then I'll still go infra-umbilical. But I am not like nearly as dogmatic about it as some of my partners who will like only go through the belly button. That's the only way they'll do it. And we have not seen real high rates. I mean, it is something that we've been thoughtful about. And it's always something that we sort of ask if we have a surgical site infection, is like, was it related to going through the umbilicus? And our surgical site infections at the umbilicus are like less common than our surgical site infections elsewhere. But I think that the reason for that, the reason it works is because of those interrupted stitches, maybe. That's just like, there's an easy way for fluid to get out and you don't get a lot of fluid accumulation. But I think, yeah, of all of the population where I feel comfortable doing it, the umbilical hernia where it's like just sitting right in front of you is probably, I think, the best case for it.
Hi, this is Tim Berkseth up with Mayo Clinic Health System in Northwestern Wisconsin. Thanks for your talk.
Yeah, of course.
Kohler. Question, I don't see a lot of patients with this. I'm in a critical access rural hospital, but I have seen a few consultations, and, generally I, just primarily educate, reassure
Mhm.
parents that we can safely wait. I have had a time or two where, patients or parents are more adamant about fixing it. Is this something that you think, using that video that you described in the office is something that would be reasonable to do, to say, look, we're looking at this, it's not just me telling you this is something that the surgical collaborative of Wisconsin is using?
Yes, I mean, I think like that's specifically the reason we designed this, was to be that resource. Um, and I think it's also really helpful now that there is a guideline from Choosing Wisely that people can be pointed to as well. I think that that's like a pretty trusted brand. I'm not sure how like aware parents are of it, but certainly for like primary care docs, like if you're referring someone back who's been sent for surgery, and you say, actually like look at the Choosing Wisely, they should all be very familiar with it. But yeah, the idea of those videos is that they're nice, they're short. I think you could someone could watch them in the office, or you could even sort of preemptively say like, happy to see you in the office. Before you come, you may just want to check out this informational video. Um, and the idea is that sort of resource will be out there. And I think like you've just put your finger on like the value of the collaborative, right? Is like it creates a community of people who can sort of say like, yeah, totally back you up in this approach.
Sure. And then my second question was about that Choosing Wisely statement. I hadn't seen that before, so I guess I thought it was interesting because, you basically said, how many of these are being done by non-pediatric surgeons, but clearly that whatever guideline or recommendation specifically says referral to a pediatric surgeon. And again, especially in areas where I live, in rural areas, it's a long way to go to a pediatric surgeon. So I was just curious if, did the pediatric
Yeah.
surgery community have, input into that or not?
I think it was written by the pediatric surgeons, which is why it says pediatric surgeon. I think the target audience is actually primary care physicians. So I think that the point that they're trying to get to is send the kid to a surgeon who operates on children, when
Sure.
they're 4 or 5. So it's basically, I think, trying to avoid those referrals, and to sort of creating that sense of self-efficacy among primary care docs, to sort of feel comfortable like waiting unless there are problems, to send the kid to a surgeon until the kid is older. But I don't think, and I've spoken with the people who authored that statement, and I don't think that the intention is to say like umbilical hernias must be repaired by people who have had 2 years of fellowship training in pediatric surgery. I think that would be crazy.
Sure. Gotcha. And just as a side note, you mentioned Dr. Densmore. So when I went to the Medical College of Wisconsin for medical school, and when I was a third year doing my surgery rotation at St. Joseph's, he was my chief resident, and he
Cool.
was a great mentor. So I love that guy.
Yeah, he's awesome. It's been, he's always like a voice of reason around all these things. I tend to be like the hothead, and he's like, yeah, okay. It's fine. Yeah.
Well, thanks so much for your presentation. Really appreciate it.
Absolutely. Yeah. Thank you for coming. And I put back in the text there the code to text in case you didn't get it from the presentation. Any other questions?
Extrapolating to children who are older, is there any time when you would use a surgical mesh? Say a 16-year-old who seems to have ended their growth stage, or I don't know. I'm just trying to envision an scenario where it may be useful, or in the adult literature, they're sort of getting away from it a little bit, but it's still, I think, fairly recommended. But where does a patient transition from child to adult? Is it when they stop growing at a certain age? What's your impression?
Yeah, I think it's when they've sort of fully grown. For the other example is inguinal hernia repair. So we use no mesh in our inguinal hernia repairs, and we do like a ligation of the patent processus. We do them laparoscopically, where you basically just pass a little thread around the the patent prosthesis and you just like cinch it down like a purse string. And people have actually tried doing that in adults, like pediatric surgeons have gone out and tried to apply that to adults, but that would make me nervous. I think like for a fully grown patient, I actually refer them to the adult surgeons because I don't do enough mesh repairs to like consider myself good at it, certainly not laparoscopically. And I think umbilical hernias would be sort of the same story. Like if a patient is coming to you and they're fully grown and they've got a significant umbilical hernia, then I would just treat them like an adult. But I would want them to be pretty confident they were like fully grown. I guess the benefit to the pediatric repair is like you don't burn a lot of bridges. Like you go in, you make a little fascial ridge there, and kind of small amount of dissection, and then you put in absorbable sutures. So if it were to fail, it wouldn't be terribly difficult to fall back on the sort of more traditional adult approach. All right. Well, we're going to be doing this talk one more time this afternoon from 4 to 5. So if you've got run into colleagues in the break room over the day today and want to send them our way, that'd be great. And then this is actually going to be the last time in the near future, at least, that this talk is given, because I am leaving next week to move to California to take a job at UC Davis. So the idea is that our hope was to get 2 good presentations today, to have those available as online resources for people going forward. My hope was to get some good questions in and have a good lively session, and so I'm thrilled to have done that already once today. We've already got a totally usable recording to be used for our enduring sessions, but if you want to send anyone our way this afternoon, we'd love to see them. And otherwise, thank you guys so much for coming. This was great, and thanks for taking care of all those kids out there.
One last
Thanks for the talk. It was great.
quick question I had. So
Yeah.
I have one pediatrician in our health system. So if I send him the email that had the link to the Zoom meeting, would that work this afternoon if he wanted to watch it or listen in?
Should, right, Rebecca?
Yes, it's the same link for both meetings. Same link, meeting ID, everything.
Okay, great.
Yeah.
Perfect. Thank you very much.
There will be
Best of luck with your
code. Oh, thank you so much. All right. Well, thank you both for coming. This was awesome. And yeah, take care out there.
All right. Safe travels.
Thank you so much. All right. Take care.